members of the Diplomatic Corps, Chief of Staff of the Guyana Defense Force, Commissioner of Police, permanent secretaries, special invitees, members of the Task Force on Narcotics and Illicit Weapons, members of the media, distinguished ladies and gentlemen all. It gives me great pleasure on behalf of the Ministry of Public Security to welcome you to this significant ceremony for launching the Guyana Household Drug Prevalence Survey Report 2016, sponsored by the Organization of American States. We are truly delighted by your presence. The effects of the drug problem on Guyana continue to evolve steadily. A thorough assessment of the situation is a complex responsibility, as there are many multifaceted issues that require consideration. Furthermore, many of the dynamics involved are yet to be clearly assessed with any assurance, as much of the authentic information is still lacking. Recently, however, surveys were done with the assistance of the Inter-American Drug Abuse Control Commission. First was the Secondary Schools Drug Prevalence Survey. The report of this survey has already been released. Second is the National Household Drug Prevalence Survey. That report is now being launched. Together, these two reports provide some scientific evidence needed to better guide and develop counter-drug policy-making initiatives that were previously guided by subjective circumstantial information. Both reports are available on the ministry's website, and it can be accessed there. Additionally, under the National Anti-Narcotics Agency, when opened, the mission of the Drug Information Network will be to develop national drug information systems and foster systematic research on the drug problem for the purpose of monitoring trends, developing policy, and implementing appropriate programs and responses. In the present circumstances, however, it is generally believed that one key impact of drug abuse on Guyana is the negative health consequences experienced by our citizens.
It is always refreshing to experience unity and commitment in addressing grave issues affecting our society and our region. Unity it is, as this morning the stakeholders and driving forces in Guyana, even representatives of the government, international partners, civil society organizations, and churches come together with a sense of purpose to launch the report and present the findings from the 2016 National Drug Prevalence Study. And we know that with unity, no solution can be out of reach and no challenge can withstand without improvement for too long. The Organization of American States, OAS, through the Inter-American Drug Abuse Control Commission, CICAD, was pleased to support Guyana in the implementation in 2016 of the Household Survey on Drugs. The results of this survey will surely contribute to better equip the relevant authorities in Guyana with the information that they will need to estimate the national level of drug use, to define the characteristics of the persons who are users, and to fine-tune policies in this regard. I would like to thank the government of Guyana for partnering with the OAS on this important project. Also, I wish to salute the drive of Minister of Public Security Kemraj Ramjatan and his staff. Further, I thank U.S. Ambassador Perry Holloway for the financial support of his government. Conscious of the dire consequences of drug abuse and trafficking, the OAS has been spearheading regional efforts to stem the plague and help the victims. We are aware that these consequences impact all walks of life and all quarters of society. Early November last year, the Director of Public Prosecutions signaled the urgency to curb woes in society at a sensitization workshop. She referred to the gruesome story of a Guyanese woman who was lured to a hotel in Georgetown only to wake up the next morning in an empty room with her genitals mutilated. That terrible crime was facilitated by date-rape drugs. Facing successfully the drug drama is a complex task. Repression alone does not measure up, as we well know. Therefore, we need a sophisticated toolkit, including sensitization, prevention, and treatment. In short, a holistic approach to the issue.
It's a pleasure for me to be here today, and the U.S. government is very proud to have been able to contribute funding to this important project, and we're very grateful to the OAS and especially the CCAD office for its fine work in this area. They are clearly in the region the leaders and the experts that all countries normally do turn to and should turn to if they don't, for guidance, advice, and assistance. Our shared goals on projects like this as stakeholders are to learn the scope of the problem and identify ways in which we can provide alternatives to drug use amongst the Guyanese youth. Drug use, and more importantly, drug trafficking, have multiple negative impacts upon all of our societies and all countries and all families. Success requires a balanced approach that tackles both the supply and demand for drugs. Educating young people about the dangers of drug use is certainly an important part of this approach. If I were to kidnap you guys and drop you in the middle of nowhere and not tell you where it is and give you a map of Guyana and say you need to get back home to Georgetown, I point you in the map. If you don't know where you're at, you might be in Lethem, you might be in Berbice, you might be in Region 1. Without a map and knowing where things are, you can't get to Georgetown. And that's what makes studies like this so important, because they give us a baseline of information where over time we will be able to measure our efforts. And I will caution members of the media and members of the public. I've seen a lot of these studies, and almost every study I've ever seen shows drug use is up, or it's a high number, it's alarming, and that's true whatever country you go to. But over time, there is a way to lower the scope and the slope of the actual consumption. But it is not something done overnight. There are no silver bullets, but we all need to work together. Through the Caribbean Basin Security Initiative, the United States government is committed to working with all stakeholders in the region to address these issues. Some very quick examples: through USAID, we continue to assist youth in building the skills and knowledge necessary to find legitimate employment, thus reducing their chances of falling into drug use or trafficking. We work extensively with the GPF, the GDF, and CANU to train and equip personnel to better fight the scourge of drugs. The opening of the local DA office has greatly increased our ability to coordinate with these agencies on efforts and operations.
I'm grateful for the opportunity to present the key findings of the household drug survey. The study had some 5 key objectives, and the focus there was to detect pattern in drug use, substance use, to determine the prevalence based on certain socio-demographic and other characteristics, to look at the patterns of substance use, and to assess persons' perception of risk of harm with regards to use of the various types of substances. The population that we used was selected randomly, persons ages 12 to 65 years old. Members were, as I said, randomly selected. The total sample size at the end were 2,367. Interviews were completed. Our response rate was 95.4%. In terms of the regional distribution of the sample, the sample selection was done based on a proportional representative approach. Therefore, the regions with greater population would reflect greater numbers in the sample. The sample, in terms of age, we had over 55% female and just over 44% males. To correct the sample and to bring it in line with the census distribution, we weighted the sample. In terms of the age group, the sample in keeping with the census distribution, the majority of the sample was from the 12 to 24-year-old age group. In terms of the educational status and employment status, 49% of the sample were either working, employed, or self-employed. With regards to educational level, we had just about 26.1% of the sample with primary education and below, and just about 7.2% of the sample with tertiary level education. So we're going to look at some of the findings of the survey. We want to start with respondents' perception of harm in terms of the use of the various substances. I want to start with the 13.1% on the bottom right-hand corner of the results. 13.1% of the sample felt that if you occasional use of marijuana, there was no harm with occasional use of marijuana. And this is something that reoccur not only in this study, but in a rapid assessment that we did. They feel that if you use marijuana occasionally, there was no harm. However, what is important to note that in terms of perception of risk, respondents in the majority felt that the utilization, being drunk often was the highest, was high risk. And so the majority of the respondents felt that the risk for getting drunk was higher than any other, in their perception, any other substance use. The next question we related to illegal drugs, and we asked in terms of their ability to access the different types of illegal drugs, and we focused on which the drug that they felt it was easy to access. As you would notice, marijuana they felt was the easiest drug to access. 40.9% of the respondents said that marijuana was easy for them to access marijuana. Cocaine, 19.8%, crack cocaine, 10.0%, and ecstasy, 9.1%. And ecstasy is a drug of some concern to us. For somehow, when we matched the results of this survey with the results coming out from law enforcement, there is no match in terms of the ease of access for what we're getting from respondents.
So you're saying not a lot of ecstasy is being found? Is that what you're
Yes, not a lot of ecstasy is being found, but here we see that some people think that it's accessible. Next slide. The next slide we look at in terms of talk about access. We asked those persons who were, if you were offered marijuana, offered an illegal drug, 25.6% said yes, they were offered an illegal drug by either a family or a friend. And then they were offered illegal drugs. So that's it. 25.6% said they were offered an illegal drug. But then we actually looked at those persons who had a family or a friend who used marijuana, and we found that when we asked them if they were offered a drug, 57% or 58% on average said, yes, we were offered an illegal drug. And those who had no friend who used an illegal drug, just about 14.5% said they were offered an illegal drug. Now, so our conclusion here is that if you had a friend or family who was using some illegal drug, you are 4 times more likely to be offered an illegal drug for use. Next slide. The next thing we looked at is the age of first use. For tobacco, the age of first use across the general population was 17.7 years, alcohol 18.7, marijuana 18.9, crack 19.8, cocaine 22.6 years, and ecstasy 23.8 years. In terms of the prevalence, so we looked at lifetime prevalence, past year prevalence, and past month prevalence. So lifetime prevalence we refer to if they would have used the drug at least once in a lifetime. Past year prevalence if they would have used the drug in the last 12 months. And past month prevalence, which we sometimes refer to as current use, those would have used the drug in the month prior to the survey. For tobacco, well, let's look at the high one, alcohol. It was 67.2% lifetime prevalence. Annual prevalence was 46.2%, persons who use, and current users were 32.5%, and those figures were generally higher than the other figures. In terms of tobacco, 26.2%, 12.5, 10.5. The other marijuana was 9.8, 4.6, and 3.3 for current use. And the other drugs below 1%. In terms of tobacco and alcohol use by sex, males, to a significant extent, outnumber females, and this is within the male population. So within the male population, 47.2% were current users in terms of use within that month. For females, 17.7%. Within the male population for smoking, it was 18.1%, and among females, 2.9%. And those are current users for tobacco in the blue, alcohol in the red. Next slide. And then we look at the age range for use. Within the age range where there's higher alcohol prevalence, the use of alcohol prevalence, and this again is current users, those who use within the month. If you note, the males between 25 to 34 are just close, almost half, 4 out of 10, of those respondents would have used alcoholic beverage within that month or considered current users. So the age range in which we have high current use would be the 15 to 54 15 to 54 years old. But across the board, except for the 12 to 14, it's generally high, more than a quarter. Moving over to tobacco, the trend goes up as they get older. In terms of, we find the 45 to 54 category where within that age group we had 16.3% using tobacco or current users of tobacco. And then we looked at alcohol and tobacco use by region. We found that for the hinterland region, 38.5%, so there was pretty high current use in terms of alcohol within that region, followed by region 2, and then region 4, and region 6. So, and all of those were above 30% treated. In terms of tobacco use, region 5, Mahaica Berbice had high, followed by the hinterland region, and then region 6, and followed by region 4.
I want to immediately thank the OAS and the Inter-American Drug Abuse Commission for their fine work in sponsoring this 2016 household drug survey in Guyana. This comes after a major survey of drug use among secondary school students was launched in 2015. Drug use among households across the country is a most welcome piece of information any country should want. These cold, hard facts about the state of our households as it relates to those households' use of licit and illicit drugs, tobacco, alcohol, marijuana, among others, as we saw, tells a worrying story. Behind these statistics, too, we will come to know what we have become and what we can do about it. I have been fortunate to get this preview of the findings of the survey from Michael Atherley. I think it's about a week now. And with Michael's permission, I wanted to state some of these findings. Now, these were repeated by some previous speakers, but stating them makes me feel so disheartened, in a sense. The objective, as we know, in relation to this survey, were to determine the prevalence of these psychoactive substances in our households in Guyana and to see what patterns of use were being put to them. And these findings include, and I'm glad that they shared around a set of a brochure there that stated these. Almost 41% believe that it's easy to access marijuana. No, that's telling us plenty. Almost 20% of the respondents believe that it is easy to access cocaine. 65% believe that the drug has increased in Guyana in the past years. 46% of the respondents believe that drug use will get worse in the coming years. 56% believe that the drug use issue is among the core concern of government, while 92% of respondents indicated that they do not know of any drug awareness or prevention programs in their neighborhoods. And then, of course, alcohol binge drinking among current users are as high as in males, 64% and over, and in females, 46.3%. And of course, the lifetime prevalence, as mentioned by Clement, and the use of alcohol and tobacco and marijuana over the year and over the month. And then there is also a kind of a geographic portrayal of what respondents say in Region 3. 21% of them said that there's a great deal of drug dealing in their neighborhoods. And that also goes for Region 7, where 24.5% of the respondents therein said that great deal of drug dealing in their neighborhoods. My intention here is not to create a moral panic, but in all honesty, and I wish to repeat the words I used at the school survey launch, these statistics paint a picture which shames us all. It's an outrage, and we have to do something about it. These troubling statistics are corroborated by what our traffic chief recently informed me about. Already from that period, 1st to 15th of January 2017, as compared to 1st to 15th of January 2016, cases made out of driving under the influence of alcohol tripled. Last year, 2016, there was 89 for that period. It is now 228 in early 2017. It does some damage to your, sense of caring and all of that. But I want to also mention a couple of things about the links between drugs and violence, and the fact that there is definitely a link, and the fact that we have seen how excessively Guyanese drink and use marijuana and use tobacco and all of that. It shows a development that will be extraordinarily negative. Drugs misuse and violence both act as a catalyst for each other. Studies show that drug consumption is linked to drug abuse and delinquency and antisocial behavior in adulthood and educational failure. Not only does drug use affect physical and cognitive functions, but it also contributes to reduced physical control and the ability to recognize warning signs in potentially dangerous situations, which can make some drinkers easy targets for perpetrators of criminal acts. Additionally, individuals' expectancies and societal beliefs about the effects of drugs, that is, we found them there, increased confidence and increased aggression, can mean that drug is consumed as a preparation for violence. Victims and children who experience and are subjected to drug-related violence strongly develops emotional and behavioral problems and are often known to seek the use of drugs as a coping mechanism. As such, this domino effect of drug abuse now becomes an economic burden to the state, since both the health and the criminal justice sectors are directly affected. Apprehending and treating offenders of and victims of drug-related violence is costly. That also diverts resources from other health and crime-related issues. And of course, social consequences of drug-related violence should also be considered, since it can extend beyond the individuals involved, individuals who are perpetrators and individuals who are victims. A high prevalence of drug-related violence within a community can also affect the quality of life, thus reducing community cohesion, increasing fear of crime, preventing persons from visiting areas which have these disorders, especially areas at nighttime. And all of that can do serious damage. One of the most robust findings in drugs, especially alcohol and crime research, is that drug-related incidents frequently occur late at night and in the early hours of the mornings and weekends. And of course, it is based on these kinds of studies that caused me to do that curfew at 2 o'clock, of course, of which I'm getting a good piece of battering for. But I also, in the research department, asked that some research be done, and they came up with a very important study out of Norway, drug in Norway, use, consequences, and cost. And the grave impacts associated with drug abuse in that study, I think it's 2011, major study, resulted in increased mortality rates due to motor accidents and increased health problems, increases of several diseases such as liver and lung, cancer, and heart diseases. As a consequence, the government there was faced with the task of additional healthcare facilities, resulting in the need for and utilization of more resources. Other negative consequences included mental health problems and behavioral disorders. Another one was a range of health services had to be introduced. Crime increased. And we're talking about Norway here, you know. Loss of productivity because of worker absenteeism. Loss of life years, low quality of work. Negative consequences on family through unstable and problematic childhood. An increased risk of divorce because of liquor and drugs. Though we in Guyana have not carried out such an extensive specific study on the cost and impacts, these negative consequences in Norway must ring a bell and warn us that here in Guyana, we too suffer from these adverse consequences, and probably many times worse. I say so because in this household survey, surprisingly, respondents seldom reported any ill effects of their drug use. On the contrary, many highlighted what they considered as desired effects of drug use, in particular marijuana use. Further, the respondents associated with a treatment center pointed out that treatment centers face three main challenges: financial resources to scale up interventions and treatment, lack of trained specialized human resources, and the capacity to monitor persons on treatment to assess progress towards rehabilitation, as mentioned by Purnell. Now, as we all know, Norway is not cash-strapped, as we are. And that is why, when ringing a bell and a warning sign, this is so disastrous in a sense for Guyana. I am happy that there are a set of recommendations made in view of these findings. These will have to be added to the efforts coming from the law enforcement standpoint, namely that which was stated in the Drug Strategy Master Plan 2016 to 2020, to be executed largely by the two existing agencies, Customs Anti-Narcotics Unit and the Guyana Police Force, soon to come under the umbrella of NANA. And of course, I here want to also restate some of the recommendations proposed to curb what is happening here. There is need for this regular sensitization of the harmful effects of licit and illicit drugs, as mentioned by Clement. We need more public spaces, recreational centers for individuals at the various stages in the cycle, because this, of course, is going to remove them from the idleness that are born in their heads in the time of desiring all these drugs and alcohol. Of course, the expansion in job training and economic insertion activities, that's very important. We have to create, of course, the mentorship programs for youths coming from the communities, and I'm glad that we are having the CSSP program on stream in relation to at-risk youth, which is going to help. But we have to also ask parents to do a better job. Parental involvement is critical. And of course, we ask the media. The media campaigns targeted at youth should also address the role of parents in drug use prevention. All of these and much more we have to do. But we must never be daunted by the task at hand. To enjoy this country in a couple of years mean we must put in the efforts now. I am glad that with studies and surveys like these, our efforts will be more clinical, more evidence-based. Thank you very much.